Hi everyone, this is Neel Raithatha, consultant audiologist and director of earwax. Thank you for joining me in my latest video, and this is of a very interesting case that I alluded to in yesterday's video. It's of a patient who attended with a keratosis obturans in their right ear, and this is a grade 3 classification keratosis obturans, and I'll explain the grading system a bit later on in the video. And ironically, this patient attended yesterday, the very same day I treated the case that I uploaded yesterday of a grade 2 keratosis obturans. So this patient has previously visited me, I think it was in 2021, and it was the first time they'd visited me back then. And I diagnosed them at the time with keratosis obturans and advised them to attend on a regular basis. But similarly to the patient who attended yesterday, who also previously attended many years ago, they left it a few years. And that's because this condition is a benign condition, and once treated, your symptoms alleviate. And it's only when your symptoms return that you really realise that you should have come sooner. So both with this patient and the patient video that I uploaded yesterday, I'm going to contact them in a year just to remind them now, because even if in a year they don't have any symptoms, we know there's going to be an accumulation of keratosis, this dead skin plug, and I'd rather remove it on an annual basis because this is quite an extreme case and it's going to be a lot of bleeding. The patient was in complete comfort, so the bleeding came from the destruction of granulation tissue, which has its own blood capillaries, and upon removal, you'll see some granulation tissue that I remove. It's a fleshy piece. I think it's going to come up in a moment, actually. It's going to be near the floor of the ear canal, so keep an eye on that. So I will explain what keratosis obturans is, because I think it's possibly a condition that may be underdiagnosed. It may be mistaken for earwax. When I first came across it, it was as soon as you touch it, so appearance can be deceptive, so you can look at a keratosis obturans and be fooled with believing it's wax, but it's only when you touch it. So with the sucker or an instrument, there's a massive difference in consistency. And the very best way I can describe it, it's like a rubber ball. It really is. It's very elastic, very springy, and it's really difficult to remove. And I know there's cases of keratosis obturans whereby it's so painful for the patient that they have to undergo a general anaesthetic to have it removed. So these are kind of really can become extreme conditions. Now, the major symptom to be diagnosed with a keratosis obturans is otalgia, which is the medical term given for ear pain. Now, can earwax alone cause pain? Yes, it can. But obviously a lot of people suffer from earwax, and I wouldn't call pain one of the primary symptoms of earwax. So whenever a patient contacts our clinic to book an appointment, my clinic manager and deputy clinic manager, I've trained them to triage the patients, just so I've got some kind of prior information before the patient attends. And of course, when the patient attends, we conduct a history. And whenever, one of the questions are you suffering from pain? And whenever a patient advises yes, more often than not, they attend with a keratosis obturans. Now, I do see a lot of keratosis obturans, probably more than most people, just because I know this can be very difficult to remove, so a lot of specialist colleagues of mine do refer these cases to myself. So, although it's painstaking at times, it is my favourite procedure. I absolutely, really enjoy the challenge of removing a keratosis obturans. Now, for anyone who doesn't know what a keratosis obturans is, I'm going to explain what it is now. So, keratosis obturans is a benign accumulation of shedded dead skin cells in the ear canal, and it forms into a plug in a lamellar arrangement. So when we say lamellar arrangement, is think about an onion, and you've got these different layers, and these layers of skin, so when the skin dies and sheds from the ear canal, they should individually flake. So the skin that's lining the ear canal at the moment, the outermost layer, the individual skin cells are interconnected, so they are binded and bonded together. But as the skin migrates towards the outer third of the ear canal, the skin cells should stop locking together. The interlocking mechanism is seized, and so the individual skin cells should come apart separately. You're going to see that granulation tissue in a moment. There's a lot of granulation tissue, but you're going to see one piece that kind of comes away in a fleshy segment. I think that's coming up now, so I'll just pause. There we are. And it's actually just got suction up the tube. And so this skin plug, it accumulates in the osseous portion of the ear canal. So the osseous portion is the bony part of the ear canal, and the bony part of the ear canal is the inner 2/3. So it's about 0.8 millimeters, into the ear canal to the eardrum, and the average length of the ear canal is around 2.6 centimeters or 26 millimeters. In terms of the incidence rate, so I did a lot of research about this, and again, I think it's probably underdiagnosed. But they say 4 out of 5 patients who attend ENT or audiology with a complaint in the ear have a keratosis obturans. But I think that figure is significantly higher, personally speaking. And in terms of epidemiology, it's normally, when you get keratosis obturans, it's not always in both ears. So I think 50% of cases are bilateral, 50% cases are unilateral, so singular in one ear. And in terms of age, the most common age to develop keratosis obturans is before your 40s. And the optimal age is the second decade of life up to your fourth decade of life, so between 20 and 40 years of age. And researchers indicate to me that females are more prevalent in having keratosis obturans, but anecdotally, at least, I think for myself, it's mainly males that I see. So that's an interesting kind of observation I made, that I found there during my research. And the clinical symptoms of keratosis obturans, as I said, the primary one is acute otalgia, so very sharp pain. It's not a dull ache, it's really intense. And of course, when your ear's blocked like this, you're going to have a conductive hearing loss. So when we say conductive hearing loss, it's when sound can't travel efficiently either through the ear canal or the middle ear system, so where the eardrum and the 3 ossicles are. If you've got damage to the cochlea, the organ of hearing, or the auditory nerve, the hearing nerve, we call that sensory neural hearing loss. And very severe cases of keratosis obturans, so we're talking about your grade 4s, patients can also present with facial palsy, so droopiness of one side of the face. Can also cause sensory neural hearing loss, so this could really grow into the middle ear, into the inner ear, and cause damage to the oval window, the round window, which is parts of the cochlea. I would say that's very, very rare. It can also cause a dehiscence of the tegmen tympani. So the tegmen tympani is a thin plate of bone that separates the intracranial compartment, so where your brain sits, and the middle ear. And again, these are really, really extreme cases. So, and the physical presentation, so as an audiologist, when you or an ENT or doctor, when you come across this, so as I mentioned, it's an epidermal skin plug located in the inner 2/3 of the ear canal. And another general hallmark of keratosis obturans is you have this white silvery peripheral matrix, and you'll see that here, particularly on the right hand side of the ear, actually all the way around. It's more visible on the right hand side of the ear canal, but you will see it all the way around. So now all this blood, it's not because we've nipped the patient, it's the granulation tissue, and I'll explain what granulation tissue is later. And the mere presence of this granulation tissue, you would grade this as a grade 3, because that's how you differentiate a grade 3 and a grade 2. Another common hallmark of keratosis obturans is this global bony widening and remodeling of the osseous part of the ear canal, so the dilation and distending of the ear canal. And this widening occurs due to the physical pressure exerted by this rubber skin plug. So it compresses against the temporal bone, which is the bone that encapsulates the ear canal. And remember, the temporal bone is regarded as one of the strongest bones in the body. I think only the femur bone is stronger. And also due to a process called bony resorption. So I did explain this yesterday, but sitting on the surface of the bone are specialized skin cells called osteoclasts, and the pressure of this epidermal skin plug activates these osteoclasts. And what osteoclasts do, they break down and dissolve bone tissue and minerals, and they release it back into the bloodstream, where other parts of the body can reutilize the bone tissue and minerals to form new bone. And that's performed by other specialist cells that sit on the bone called osteoblasts. So quite common with keratosis obturans, you get this global widening now. With a canal cholesteatoma, they're generally more localized. They generally appear on the floor of the ear canal or the posterior or anterior, so the front or back part of the ear canal. With necrosis, so benign osteonecrosis, which is another condition where you can get an erosion of the bone. That happens at the floor of the floor of the ear canal, so the base of the ear canal. So keratosis obturans is more around the complete periphery of the ear. One of the key differentiators between keratosis obturans and a canal cholesteatoma, other than what I've just explained about the global widening as opposed to a canal cholesteatoma, which is more localized, is that there's no ulceration. The underlying bone is not visible, it's not exposed, the skin's intact. And with a canal cholesteatoma, you actually get erosion of the bone. So that bone is decaying, it's necrosis because it's diseased. With a benign osteonecrosis, that bone does necrose, but less so due to bacterial involvement or disease of the bone. It's just due to a lack of blood flow. Here, the bone isn't technically eroded. It's just, it depends how you define the word eroded, but the outer layer of the bone is breaking down and the minerals and tissues are just being redistributed. So, but technically you could call that erosion, couldn't you? Patients with keratosis obturans, because they've got a lot of keratin production, they can get a thicker outer layer of the eardrum, the cuticular stratum. So the eardrum is three membranes thick. You got the outer layer, which is made up of the same epidermal skin cells that line the inner 2/3 of the ear canal. You got the fibrous stratum, which is the middle layer of the eardrum, where you've got fibrous connective tissue, and the innermost layer of the eardrum is made up of stratum mucosa, which is made up of mucosal skin cells. So mucosal skin cells are similar to the skin that lines the inside of your nose, so it's more secretory. So as I mentioned, with a grade 3 in particular, you can quite often get bleeding when you remove the matrix of that white periphery silver matrix, and that's due to neovascularization. So because this plug is really compressing against the ear canal, you get inflammation, and when you get inflammation, you get inflammatory tissue called granulation tissue, and granulation tissue has its own blood capillaries. And this granulation tissue normally occurs at the osseo-cartilaginous junction, so where the cartilage section of the ear canal, so the outer third, meets the bony part of the ear canal, the inner 2/3. And it's very apparent in this ear, actually. So the granulation tissue is primarily found in that, just where that flesh is on the right hand side, that's the cartilage part, and where the suction probe is here, where I'm trying to pull this the white silvery matrix, you're going to see all the granulation tissue, and it's going to bleed quite a lot. That's the bony part of the ear canal. And quite often, again, with keratosis obturans, which is again very apparent in this case, you get inflammation lateral to the epidermal skin plug. So when we say lateral, we mean in front of this plug, and the cartilaginous portion of the ear canal is quite inflamed. You can see it on the right hand side, that the fleshy part of the ear canal, that's quite inflamed. And that can sometimes give a pseudo appearance of a larger widening that there actually is. So because this section of the ear canal is inflamed, it's like an hallucination. It makes the bony part of the ear canal look wider because the cartilage part of the ear canal is inflamed. So it can sometimes fool you into believing the erosion, the widening, is bigger than it actually is. Now, terms of the severity, so I discussed the grading system. So grade 1 is when a patient attends with mild pain, and there may not be any discernible expansion of the ear canal, so there might be a bit of a widening, but nothing significant. Grade 2, which is what I would classify the patient yesterday's keratosis obturans as, you kind of get a moderate pain and a mild expansion of the ear canal. With a grade 3, you get a moderate to a severe pain, and this patient did report kind of in that kind of range. They said it was more moderate pain. And then you get a moderate expansion of the bony part of the ear canal, And importantly, with a grade 3, which is the differential from a grade 2, you get granulation tissue at the osseo-cartilaginous junction, which I've just explained. Grade 4, these are your extreme cases. I think I've only ever come across one. Grade 4, patients are generally going to go to A&E. They're not going to go to the doctor or, well, they can, but more often than not, the pain is that severe. They're going to go to an accident emergency and be treated in hospital as an inpatient. But so a grade 4, severe pain, severe expansion of the ear canal, and this expansion can expand to the mastoid bone, which is the bone behind the ear canal, which can also cause, that's what can cause the facial palsy, because the facial nerve runs on the back part of the ear canal, more on the top section of the back part of the ear canal, so what we call the posterior superior aspect of the auditory canal. So if that bone on the back where the mastoid bone it's widened significantly because of the keratosis obturans, it can affect the facial nerve. And as explained earlier, some other severe cases, it can go upwards. It can cause a dehiscence, so a breaking down of the tegmen tympani, which is the bone that separates the intercranial compartment and the middle ears. But they're your really, really extreme cases. So what's the pathogenesis of keratosis obturans? So in a nutshell, it's when you've got increased keratin production. And increased keratin production, so keratin is a protein that's found in the skin cells in the ear canal. It's your fingernails and hair is also made up of protein, keratin. So if patients suffer from eczema, so if you've got any allergies, the skin, that can lead to higher turnover of dead skin. Dermatitis, furunculosis, if you've got a furuncle, so a furuncle is an infection of the hair follicle that typically happens in the outer third of the ear canal though. And any potential causes that may lead to chronic inflammation. So for example, psoriasis. So psoriasis is an autoimmune skin condition. The brain, the body attacks the healthy skin thinking it's infected, and you can get a lot of inflammation. And inflammation results in increased blood flow, and the more blood flow you have in the ear, the more skin production you have, and the more skin production you have, the more dead skin you're going to create. And another potential reason is the abnormal migration of skin. So the skin that lines the ear canal and the outermost layer of the eardrum, as that skin dies and sheds, it should move slowly sideways out of the ear in a conveyor belt motion. I gave the analogy yesterday. If you think about a snake, when a snake sheds its skin, the snake comes out of the skin. So it's similar to that, but the opposite. So with the ear, this dead skin comes out of the ear. Obviously, the ear can't come out of the dead skin. And sometimes the abnormal migration is that the skin moving from the deepest part of the ear canal to the entrance, the skin migrates inwards to the center of the ear canal. So the migration pattern is incorrect, and it can form into a plug. Another reason could be also, as I mentioned, as the skin does shed and migrate towards the entrance, as it's shedding, the interlocking skin cells should delock themselves. They should flake away individually. And with keratosis obturans, the individual skin cells are still in contact. They're still interlocked. So that's another potential reason. There's also been a possible link between keratosis and obturans and bronchiectasis or sinusitis. And bronchiectasis and sinusitis stimulates the sympathetic nervous system, which can then cause a dilation of blood vessels. And when you've got a dilation of blood vessels, again, you have increased blood flow. So bronchiectasis and sinusitis typically can occur more in the pediatric population. So, and then that's another reason why younger patients generally get keratosis obturans as opposed to the geriatric population. So the primary cause of keratosis obturans is excessive skin production, and you're going to get excessive skin production because the more skin you produce, the more dead skin you're going to have as a result. That's going to happen in younger patients. As we get older, we're not going to be able to form as much skin as we are when we're younger, and as we're younger we have more blood flow, which is again another inducing factor of skin production. So that's just some interesting facts for you there. So etiology, as I mentioned, inflammatory reasons. I gave you some reasons there: eczema and dermatitis and bronchiectasis and sinusitis and psoriasis, all these kind of conditions which increase blood flow. And another reason, as I said, is this the abnormal separation of the keratin, the skin. Instead of coming sideways, it goes inwards, and the individual skin cells don't flake away. In terms of treatment, the most common treatment is just regular removal. So you have it removed on a regular basis. And anti-inflammation drugs, so steroid drops in the ear sometimes, reduce inflammation, reduce kind of blood flow. There are other possible reasons as well. Treatments. And then in extreme cases, surgery. So the aim of surgery is because when you've got the bony remodeling of the ear canal, once you've got that, you're going to be having to have your ears cleaned on a regular basis because it's like a mastoid cavity. When you've got this widening of the ear canal, you get debris collection in there. The skin doesn't migrate as well. So either you fill in the widenings, and you can do that with split skin grafts, or you widen everything. And so you can ENT can perform a canaloplasty to widen and remodel the rest of the ear canal so it's more of a similar shape. Now, I said yesterday I'll explain the anatomy of the skin. So I've got another 7-8 minutes, so hopefully I can get that done. So the skin in the ear differs in the cartilaginous junction, so the outer third, and the bony part of the ear canal. So the skin in the cartilaginous portion is a lot thicker. It's about 1 millimeter in thickness. And it has 3 layers. You've got the epidermis layer, which is made up of epidermal skin cells. You then got the dermis layer, and found in the dermis layer is your collagen, your elastin, most of your blood supply there, nerves run through there, and you got hair follicles. So the hair follicles is where then you got the hair, the roots of the hairs and stems then penetrate through the dermis, through the epidermis to the surface of the ear canal. And you can see these hairs only on the outer third, just like in this patient here. And then below the dermis layer, you've got the hypodermis or subcutaneous layer, and that's made up of adipose tissue predominantly. So that's fatty tissue designed to as a buffer, protects the skin and helps retain heat as well. But when you enter the inner 2/3 of the ear canal, the osseous portion, you've just got the epidermis layer of skin. So it's absent of the dermis layer, hence why there's no hairs there. And there's no fatty tissue there. There's no subcutaneous or hypodermis layer. So the skin that lines the inner 2/3 of the ear canal is extremely thin. It's less than 0.1 millimeters in thickness, and it's directly on the bone. So that's why the bony part of the ear canal is very, very sensitive. So if you've been watching my videos for the last God knows how many years, I always stress that point. The bony part of the ear canal is extremely sensitive, and I know firsthand because I've had trauma to my ear canal before, so I know exactly how it feels. Now, the epidermis layer of skin itself has 4 to 5 layers. At the deepest layer of the epidermis, you've got the stratum basal. So the stratum basal is the innermost layer of the epidermis. And it's in this layer where the skin reproduces itself. So it's a process of mitosis, cell replication. So you get parent keratinocytes. So keratinocytes is what these skin cells are called when they are formed originally in the stratum basal layer of the epidermis. And they replicate themselves, and it creates a daughter keratinocyte. And this daughter keratinocyte skin cell is pushed up to the next layer of the epidermis called the stratum spinulosum. And the stratum spinulosum is where these keratinocytes are really densely packed. And it's this layer of the epidermis which gives the epidermis a lot of integrity and strength, because these keratinocytes in the stratum spinulosum layer is really densely packed. The next layer up is the stratum granulosum layer, and in this layer of the epidermis, the keratinocytes begin to change their physical shape and structure. So you get a buildup of granules, hence the term stratum granulosum. And the granules, you get two types. You get keratin granules, so it's protein found in skin. It develops in granules. If you look under an electron microscope, you can actually see these granules forming. And also natural moisturizing factors, so carboxylic acids, for example, they glycerol, they form in granules in the keratinocyte skin cells in the stratum granulosum layer. Now, there's a fourth layer of the epidermis which is not found in the ear. It's only found on the paddings of your fingertips and feet, the sole of your feet, and that's called the stratum lucidum. And that's where these granules kind of burst open, if you like. They're no longer present, they're not visible, hence the term lucidum. So the skin in that layer is quite transparent. But that's not present in the ear. And then you have the stratum corneum. So the stratum corneum is the outermost, most superficial layer of the epidermis. And that stratum corneum layer can be about 10 to 30 layers even itself. And this is where the keratinocytes are no longer. They're at this stage called corneocytes. So the process of a keratinocyte skin cell being formed in the stratum basal layer of the epidermis, the journey of that keratinocyte skin cell to the outermost layer, the stratum corneum, is called cornification. So they're the same skin cells, but they're just given a different name at this stage. And the corneocytes, they're actually dead skin cells. There's no metabolic action, there's no nucleus, there's no intracellular fluid, there's no organelles. Instead, the skin cell is full of keratin and these natural moisturizing factors. And these natural moisturizing factors attract moisture in the environment to keep that epidermis layer hydrated so it doesn't fully dry out. And keratin gives these bundles, they provide the epidermis layer with its rigidity, its strength. And the corneocytes, they look like pancakes. The skin cells are flat, whereas in the deeper layers, when these corneocytes were once upon a time called keratinocytes, the skin cells are more cuboidal, they had more structure, but they change shape, they change their physiology in the outermost layer. And these corneocyte skin cells, they interlock, they connect to one another, almost like body armor in the ancient times. And it's this stratum corneum, as the skin sheds, the dead layer of skin, it begins to separate from, so the stratum corneum dead skin cells begin to flake away, and we call that desquamation. It just means a shedding of skin. And as the skin sheds, it moves sideways out of the ear. It should anyway. And these individual skin cells begin to detach from one another and they flake away. So what I'm doing here, hopefully that, because I did promise I'll explain the skin anatomy yesterday. So what I'm doing here, I'm just trying to stem some of the bleeding. Sorry I've not talked about the procedure, but it was self-explanatory. As I said, it's one of the hardest things to remove a keratosis obturans. It's not easy. I suspect a few commentators may think it will be. But it's the most difficult thing to remove, I believe, from the ear. And it's just that plug, it's so elastic, it's got so much kinetic energy, it's got all this skin that's coiled over and bonded, and you touch it and you lift it off the ear canal and it flaps back, and then you've got this widening. So this plug, it feels that widening of the osseous part of the ear canal, and you're trying to bring that really rubbery plug through the lateral part of the ear canal, which is a lot narrower and even inflamed like it is in this case. So what I'm doing is just kind of stem some of the bleeding here. I may have nicked the patient. You'll see a little mark at the bottom of the ear canal. The patient didn't feel it, and I didn't feel nicking. I nicked the patient, but it's possible because this lateral part of the ear canal is so inflamed that it's sensitive to bleeding. So even if you nip it, or it could have been when I dragged it out, it's just because some of this keratin may have been a bit hardened as well. But that's the eardrum. Otherwise, healthy. So what I put into that patient's ear is called an otoblock. We put that in patients' ears when we take ear impressions, so it stops the impression material entering too deep into the ear canal. So I put that in, and it compressed that part of the ear canal to stem any bleeding, and it clotted. As you can see, it coagulated and there's no more bleeding. That's that plug of keratosis obturans, the difficult part. Well, I hope you enjoyed that video, guys. Do take care, keep well, and speak soon. Bye.